Let me share my screen. Okay, can everybody see my screen?
Yeah, it's still in presenter mode, but we can see it. It's fine.
Okay, there we go.
Oh, that looks great.
All right, so today we're going to talk about aggression and its differential diagnosis. And because I have a limited time, I'm giving you this presentation from the lens of a child psychiatrist. And even as a child psychiatrist, much of diagnosis, especially of children and adolescents, is an art versus a science. But we do have criteria we follow. And then, based on our best ability to put a case together, usually longitudinally, I'm going to cover some of the current evidence based treatment recommendations for bipolar disorder. And DMDD is disruptive mood dysregulation disorder. And then talk a little bit as we go about other differential diagnosis considerations for irritability, anger, aggression. These are some of the terms that are used to describe kids that are basically emotionally dysregulated and out of control. And what else could it be if it's not those two diagnoses? So the DSM-5, which is sort of our nosology Bible in psychiatry, defines bipolar disorder, and this is in the manic state, as 1 week where these symptoms are present for most of the time and nearly every day, of either elevated expansive mood or irritable mood. If it's elevated expansive mood, you need 3 or more symptoms. If it's irritable, you need 4 symptoms of inflated self esteem, grandiosity, decreased need for sleep, patients being more talkative, having flight of ideas or describing racing thoughts, distractibility, and excessive involvement in activities with high potential for painful consequences. So, impulsive activities. This is really written for classic adult diagnoses. Those set of symptoms are sufficient enough to cause marked impairment in functioning. There can be psychotic features, and they're not attributable to the physiological effects of a substance, a medication, or a medical condition. And you do need to have that full week of criteria to meet the full criteria of a bipolar 1 diagnosis. You can additionally have hypomanic episodes, same symptoms with only a 4-day duration needed, major depressive episodes. And when we talk about bipolar, you could have rapid cycling, that's more than 4 discrete mood episodes a year. You can have psychosis, or you can have mixture of depressive and manic symptoms at the same time. Why I thought this talk was really relevant at the time as we see healthcare sort of taking some hits as we're waiting to see what the federal government decides is that, in the Make America Healthy executive order, they have called out a concern that psychotropic medications are being misused for some kids, and particularly honed in on the controlled substances like the stimulants we use for ADHD, the benzos that can be used for catatonia or anxiety, and the atypical antipsychotics. And so I think that in general, we should always know what our diagnostic criteria are. But I think more than ever, it really is important that we make sure that our observations are accurately documented and then support medication recommendations that we're making. Now, maniac for kids, I think the challenging thing about diagnosing it is that, especially in younger children, there isn't a distinct period when a child manifests these, not as clear cut as with the adults. So you still have the same kind of symptoms: grandiosity, expansive mood, pressured speech, flight of ideas, a decreased need for sleep. Obviously, the potentially dangerous, risky behaviors are more age appropriate. So we see sexual promiscuity, excessive spending, impulsivity. It can be a sense of being very productive when they're not. It can include in kids irritability, and the impulsivity can come out as law breaking or substance use in teens, pregnancy, and aggressiveness. And these set of symptoms, this irritability, law breaking, substance abuse, and aggressiveness, are much more likely to be seen in kids with a history of maltreatment. And superimposed on that, we're looking for if there's a bipolar manic state going on. Children are much less likely to have, are more likely, I should say, to have hourly to daily changes in mood instead of the classic, more discrete, longer term episodes that we see in adults. So again, teens, adults have these distinct episodes. The pediatric presentation can be hours to like a couple of days, and much less clear episodes, and more likely to be mixed depressive manic symptoms, not just the manic symptoms alone. More continuous rapid cycling. So rapid cycling is 4 episodes a year, and much more likely to be irritable, have mood lability, and have explosiveness instead of the elation and the over happiness. What we have seen in kids, and this is taken from some of our epic notes of kids that we feel pretty certain had a diagnosis of bipolar disorder on our hospitalized unit, is giggly, silly, constantly on the go, laughing fits, feels invincible, constantly irritable, so not just stressor induced, aggressive, slamming doors, hostility in words, or screaming. Now, the prevalence of true bipolar disorder in children is 2 to 4%. With the younger you go, the going more to the 1 to 2%. So true bipolar disorder in kids, especially prepubertal kids, is extremely rare, and that's sort of important to note. 90% of kids who have a bipolar 1 episode will go on to have a recurrent episode. 60% of these manic episodes occur immediately before a major depressive episode. And again, rapid cycling is common. As I mentioned before, bipolar 2 is the same symptoms, it's just a little less duration. We see the diagnosis of bipolar 2 much more frequently in kids that have a significant trauma history or might even meet separately criteria for PTSD. So this is Ryan, and I disguised his case, but acute change over 3 months. He was a nice boy with friends, good grades, really seemingly out of the blue became irritable, defiant, disrespectful, provocative, boastful. He stole a child's lunch, threw it in a puddle. It was in my way, he says, purposely destroyed his brother's science projects, talked constantly and never seemed tired, so didn't sleep for days, more distracted than usual and annoyed to see you for an evaluation. Now, they did report some bullying as a precipitating event, and this is what is so tricky with kids, is that they can be much more reactive for persistent periods when there is an extreme stressor. And in terms of background, his background was unremarkable. So this was truly a change in his baseline state. So in general, we're looking for evidence of an episode, so symptoms that travel together, particularly if there's elation, huge unprovoked increase in irritability, increase in energy, not needing sleep, the grandiosity. We look for corroborating information, so not just the parent report, if possible, from the teachers, from anybody that has seen the child recently. And then we're always looking for other explanations. So medications, domestic situations, drug abuse, trauma, all of these can look very much masquerade like mania and bipolar disorder. And we just want to make sure that we're doing a careful assessment. And especially in kids. Rarely is this a one and done diagnosis. So you complete it in one eval. We often do this over a longitudinal period. And often these kids with these set of symptoms are on an inpatient unit where we can observe them over several, 24-hour cycles. Again, we want to think about previous significant abuse or maltreatment, post-traumatic stress disorder, kids who are going through placement transitions or have had CPS placement, can have some of these symptoms that are not true biological bipolar disorder. Kids with intellectual challenges or significant brain injury, parental inconsistency, substance use, marked early attachment problems, again, which usually show up before age 5, and then conduct disorder. So there's a lot of things that we have to keep on our radar as we think about diagnoses these kids. Here's just an example of the confusion that we have to sort through, that, traumatized kids, and you can see what's in the purple box there, the feelings of fear, helplessness, uncertainty, increased arousal, agitation, avoidance of reminders, irritability, quick to anger, feelings of guilt and shame, dissociation, continuing to feel hyper alert or hyper vigilant for threat or danger, and often have reckless, aggressive, self-destructive behaviors. And then ADHD, where they have trouble with impulsivity, hypermotor symptoms, difficulty sustaining attention. And then the overlap in both these conditions, you can have distraction, trouble concentrating in school, disorganization, hyperactivity, restlessness, difficulty sleeping, and increasingly irritability is starting, even though it's not in the DSM criteria. We see a certain group of kids where the irritability travels with the ADHD and improves with stimulant medication. I wanted to just quickly pause here. I spent 20 years as a psychiatrist to gastroenterology for kids and adults. And the number of kids I saw with autism spectrum disorder, and as we know, autism actually affects not just the brain, but these kids have trouble with immune system, metabolic system, but also their GI symptom. And the number of times that the GI symptoms, especially in kids who were more nonverbal, would lead to that GI pain came out very directly as an acute change in aggressive behavior. And so often these kiddos were misdiagnosed with bipolar disorder when in fact they were just expressing somatic distress. So bipolar disorder, when you do have a case of it, is extremely comorbid with ADHD, 90% of kids and 60% of teens. Also a very high prevalence of anxiety disorders, which often we don't screen for adequately enough once we have the bipolar disorder. And they are at a 4 times greater risk of PTSD. Now, disruptive mood dysregulation disorder is a newer DSM diagnosis. This is a group of kids, it's a large group of kids where irritability is their predominant mood state. They have problems with emotional self-regulation resulting in aggression, problems with attention, concentration, and academic performance. And often you see at-risk behavior, self-injury, substance use, suicidal threats. Why this is an important distinction, and this is the lens that I'd like you to listen as we go on, is that the treatment approach is extremely different for a disruptive mood dysregulation disorder in terms of what we do with psychotropic meds as it is compared to bipolar disorder. So kids with DMDD are characterized by recurrent temper outbursts in response to common stressors. So that's key. There is a trigger. The temper outbursts can be verbal or behavioral, and the reaction is grossly out of proportion with the intensity or duration of the situation or whatever provoked them, and often inconsistent with their developmental level. And these happen frequently, so on average 3 or more times a week. And even when they're not having one of these outbursts, these temper tantrums, these irritable temper tantrums, Their mood between episodes tends to be more irritable, angry, or sad. And then this negative mood isn't just in the context of interaction with the parent or interaction with the teachers, it's seen really across settings. They have a difficult time with transition. So you hear the term cognitive rigidity used a lot. They tend to ruminate about things and perseverate in their thinking. They may experience some improvements in some settings, especially if you have them on a low dose ADHD meds. But once that medication is out of the system, they're prone to have those meltdowns. They do better when they're busy, so inactivity makes the irritability much more pronounced, and they're prone to have behavioral activation on SSRIs that is often mistaken for mania or hypomania. In terms of the criteria, I love the frame OIVE. So outbursts that are frequent, impairing, and not just one place. The I, irritable mood, even when not having these outbursts. The V is very chronic, lasts over a year. The E is explained, not explained by other conditions, mania, major depressive, PTSD, anxiety, and autism. And the Y is starts in childhood. So this is key. This would not have an adolescent onset. We see it after age 6 and before age 10 for this diagnosis. Most of these kids have ADHD. Even a equally large percent have oppositional defiant disorder. Many of them are misdiagnosed with bipolar disorder, and they have a higher than expected prevalence of lifetime anxiety disorder and lifetime major depression. And they're 7 times more likely to become depressed, so meet a criteria for full major depression by age 18. And this chronic irritability, if it persists into their adolescence, does predict mood disorders, depression, dysthymia, and generalized anxiety disorder into their adulthood. So differential diagnosis of explosive outbursts, again, if it's rare, we're not thinking either DMDD or bipolar. We're likely thinking some kind of stress-induced condition. If they're frequent, we look for, is it an acute abrupt change from baseline versus being chronic? If it's acute change in children, we still want to think of stressors first. And in teens, if it's an acute change in baseline, we're much more likely to start with ruling out a mood disorder. If we have the chronic irritable outbursts, if they're irritable between the outbursts, then we're thinking about, or we have less irritability. Sorry, my arrows got mixed up. If they're irritable between outbursts, but there's no triggers, we think of depression, mania, and drug-induced conditions. If they're fine until there's a stressor, and then there's still irritability, but the outbursts don't last in a constant state, we think more of DMDD. Treatment. Pharmacotherapy is the primary treatment for a well-defined case of bipolar disorder. However, a comprehensive treatment plan very much includes psychotherapeutic interventions. And I think this is critical, and this is straight out of the American Academy of Child and Adolescent Psychiatry. These parameters have not been upgraded for a while, but the recommendations haven't changed. So it is challenging, and the more recent literature emphasizes how important family involvement. So you need the meds, but family involvement, family stability are extremely important. Educating with the family, working with the family on expressed emotion, DBT, dialectical behavioral therapy for the kids. Suicide prevention planning is particularly important with how these kids their mood can change, and they've got the impulsivity. And then the psychopharmacology is mainly mood stabilizers and atypical antipsychotics that have been FDA approved. This is a list, and you're going to get a copy of these slides. But if you look at that age less than 18, there are very specific criteria for which medications have been approved for the pediatric set and which medications in our mood stabilizers and atypical antipsychotics, at what age they're approved. So anything that is being utilized outside these age ranges, or if it's a medication that has some placebo-controlled trial support but not FDA approved, has to be labeled, and the informed consent has to include that you're using those medications off label for that particular child. There's several very well done studies. This one I found particularly compelling. It looked at kids who had bipolar disorder between the age of 6 and 15. They compared lithium, valproic acid, and risperidone. They were all at therapeutic doses, and they monitored for that. Across these bipolar kids, the risperidone was more efficacious than the lithium or the valproate for that initial treatment of child mania. So these were manic kids, and the lithium did better than the valproate. Discontinuation rate was the highest for lithium. With risperidone, you had weight gain, increased body mass index, and prolactin levels were elevated. And then lithium, we know, can increase thyroid stimulating hormones. So when do we use lithium? Because lithium has many side effects, and I'll show you those on the next slide. But we use it for, it's still very effective for a monotherapy for a very acute mania. Adjunctive lithium with antipsychotics while we're waiting for the antipsychotics to get on board. If there's a strong family history of episodic bipolar disorder or a family response to lithium. And we don't use it for bipolar 2. So if we're even thinking of lithium, we really want to be clear that they truly meet bipolar 1 criteria. And it doesn't seem to work very well if kids have comorbidities, and that's most of the kids we see. So really between these limited indications, and then here you have the, or these are the side effects, for the first and second generation antipsychotics, the antipsychotic monitoring that is critical for, especially if there's a family history of diabetes. But in general, any child you have on an atypical antipsychotic, you want to monitor BMI, blood pressure, fasting glucose, and fasting lipid profiles, baseline 6 months, and then at least annually. For lithium toxicity, this is where we can have problems with GI symptoms, renal symptoms, thyroid, we mentioned, toxicity if you go outside a very circumscribed dose range, acne, weight gain, tremor, polyuria. So again, even our mood stabilizers have side effects, and they're a completely different set. The list is not as extensive as it was for those atypical antipsychotics, but still, we need to do a lot of monitoring for both classes of medication. And this is really what we use for bipolar disorder. As I said, when you do have a child with bipolar disorder, ADHD is common. You want to stabilize the mania, then treat the ADHD. This goes the same for anxiety. So if it's true bipolar disorder, you want to stabilize the bipolar mood, CBT first. Only very, very carefully would you add an SSRI if truly behavioral interventions did not work for the anxiety disorder. So you want to do a very good evaluation. The atypical antipsychotics are the first-line pharmacotherapy for pediatric bipolar disorder. And again, treat the mania first, then stabilize comorbid conditions. And then last slide, in terms of treating DMDD, behavioral interventions first. So if we're going to psychotropic, though, we want to use conservative use of an ADHD medication and limit it as much as possible to the school day. Meltdowns related to perseverative frustration with inability to achieve outcomes may respond to low-dose SSRI or clomipramine. There is more behavioral activation from the SSRIs in this population, in this sample of kids. So you want to make sure that you're titrating in extremely microdose increments, and you want to make sure that you're giving the kids a lot of academic accommodations. And we only use the antipsychotics for these kids in the case of very severe aggression. And risperidone has been most studied, and again, in tiny doses. So that's it.